सुरु गर्ने हो
ल गरौँ है त
कि मोडरेटरले कुरा गर्नुहुन्छ कि म डाइरेक्टली गर्ने हो
हैन म सुरु गर्छु
ल
अनि त्यसपछि मोडरेटरले तपाईलाई इन्ट्रोडक्सन गराउनुहुन्छ है त ल नमस्ते सबैजनालाई म डाक्टर रोजित श्रेष्ठ आजको यस एप्लाइड हेल्थ एन्ड मेडिकल साइन्स सेसनमा तपाईहरु सबैलाई स्वागत छ म र मेरो साथी कोअर्डिनेटर डाक्टर सुमनको तर्फबाट तपाईहरुलाई हार्दिक अभिवादन र धेरै धेरै धन्यवाद आज उपस्थित हुनुभएकोमा र आजको हाम्रो सम्पूर्ण स्पिकरहरुलाई पनि हामी मुरी धन्यवाद दिन चाहन्छौं उहाँहरुको समय र आफ्नो विज्ञतालाई हामी माझ शेयरिङ गर्नको निमित्त उहाँले देखाउनु भएको तदारुकतालाई हामी कदर गर्दै आजको यस सेसन स्टार्ट गर्नतर्फ लाग्दैछु र आजको हाम्रो सेसनको मोडरेटरको इन्ट्रोडक्सन दिन चाहन्छु र उहाँलाई यो प्रोग्राम हस्तान्तरण गर्न चाहन्छु हाम्रो मोडरेटर डाक्टर इन्दिरा तिवारी हुनुहुन्छ सी is now postdoctorate associate in the Department of Infection Biology, Zoonosis Research Center in the Wonkwang University School of Medicine, Korea. Dr. Indira, please.
Thank you, Dr. Rojit. विश्वभरिबाट हामीलाई हेरिरहनु भएका सम्पूर्ण महानुभावहरूलाई यस फर्स्ट NRNA Asia Pacific Knowledge Convention सेसन 3 मा रहेको Applied Health and Medical Science मा स्वागत गर्न चाहन्छु. This session aims to share the innovative idea, knowledge and experience from Nepalese health professionals working or studying in various health sectors at the Asia Pacific region to help combat the existing issues of the healthcare delivery system. Apart from this, we will have young professionals, students and trainees to present their studies and foster their presentation skill through this session. First of all, I would like to welcome the chair of the session, Dr. Rojit Shrestha. Rojit Shrestha is the assistant professor at the Faculty of Health Service, Hokkaido University, Sapporo, Japan. He has an extensive experience in developing the lipid testing and biomarker for risk satisfaction of cardiovascular disease, and he served as a secretary of the Lipid and Vascular Disease Division of American Association of Clinical Chemistry. And he held up within top 100 most influential pathology professional in 2018 on the pathologist power list. Similarly, I would like to request Dr. Suman Shrestha to chair this session. And Dr. Suman Shrestha is a medical doctor and he's currently pursuing his fellowship in advanced diagnostic imaging and theranostics at Gungnam University, Japan. And he was the first Nepalese and one of the 12 international candidates to be selected for Society of Nuclear Medicine and Molecular Imaging Future Leader Academy in US in 2019. And he is the first Nepalese to receive the Barco Clinical Hybrid Imaging and Theranostic Fellowship felicitated by the European Society of Radiology at Esens University Hospital in Germany. Currently, he is working as a faculty in Gungnam University and receiving his fellowship. Now, I would like to move forward for our first part of the program, and I would like to request our invited speakers to complete their presentation in 10 minutes, and our general presenters to complete their presentation in 8 minutes. And apart from this, we would like to request our viewers to actively participate in this session by sending their queries to our NRNA Facebook page that will be discussed at the end of the session. Now, I would like to welcome our first invited speaker, Dr. Ranjit Shah. Dr. Ranjit Shah is a microbiologist working as the pioneer of establishing the COVID-19 testing in Nepal at National Influenza Center National Public Health Laboratory. He has completed his MD in microbiology in clinical infectious disease, fellowship and clinical research training from the Harvard Medical School. His main research interest is in COVID-19 and other tropical and infectious disease. So I would like to welcome Dr. Ranjit for his presentation.
Thank you, everyone. And we are going to begin my presentation. And about presentation, I would like to, since I'm the pioneer of established COVID-19 in Nepal, so we will begin from that scenario only. So beginning of COVID-19 in Nepal and its development. So first we talk about the global development in COVID-19. The first case of COVID-19 was reported from Wuhan, Hubei province On November 17, it was says that it is in the in December at the end of the 2019. But first case, according to the South China, they have reported on 17th November. Then a cluster of pneumonia cases was caused by the novel coronavirus reported from the same province by the end of the 2019. On January 30, 2020, WHO declared the COVID-19 outbreak as a public health emergency of international concern. On 11th February, the virus name was given as SARS-CoV-2, that is Severe Acute Respiratory Syndrome Coronavirus 2. Initially, it was named as the 2019 novel coronavirus. If there is any new coronavirus and the outbreak comes, then we usually name as novel coronavirus. And after, in the course of time, when we know about the characteristic of the virus, then we give a name by all of the scientists all over the world having the meeting. So it was named as a SARS-CoV-2 because it was similar to 83% and above in SARS-CoV-1. That was the outbreak which occurs in 2003. So since there was a similarity, they thought that, okay, this is the version 2, and they name as SARS-CoV-2. And before that, the disease was not named by the disease. There was no name given to the disease caused by it. And at 11th February, they named the disease as COVID-19, that is coronavirus disease 2019. On 11th March 2020, WHO declared as a pandemic, and the disease spread from the China across the 215 countries around the world, having more than 3 crores people infected, leading to around 10 lakh people death till today and counting. So what is the COVID-19 development in Nepal? On 9th January 2020, the first case came from Nepal, from Wuhan, China. The 13th January 2020, patient get admitted in Sukraraj Tropical Hospital and Infectious Disease, which is nearby Teku NPHL, that is National Public Health Laboratory. On 23rd January, declared as positive for 2019 novel coronavirus. Then on 17th March 2020, second case came to Nepal from France through Dubai and declared positive. On 22nd March, Visit Nepal 2020 was called off, and 24th March, the country-wise lockdown was started till 21st July 2020. On 4th April, we found there was a local transmission in Nepal, and on 14th May, the first case was recorded in Nepal. Till today, there is around 71,821 case positive, and among them 467 deaths already reported in Nepal and is still counting. So what were the development that was done through the ministry? And ministry wise, they have developed, like on 6 March, they developed the COVID-19 SOP, case investigation and contact tracing form. On 6 March, again, they developed the protocol of influenza-like illness clinic. Then on 15 March, they are taken as the key action to be taken for COVID-19 infection. On 15 March, again, allogrametry to suspect the COVID-19. On 20 March, information action to do the place of residency home of asymptomatic travelers. 22nd March, SOP on preparation and quarantine of COVID-19. 22nd March, COVID-19 handbook for health worker. 22nd March, again, clinical approach to a patient with suspected COVID-19. 26th March, contact tracing form. 26th March, again, reporting form of COVID-19. 26th March, again, the protocol of COVID-19 screening at PUE. Then 28th March, guideline was developed, and 30 COVID-19 technical guidelines into WHO. So these were the work which was going on. The first case was reported on 23rd January, but the second case was on 17th March. In between, there are a lot of work we were doing the preparation for pandemic. So now let's focus on what happened at first case and how Nepal responses, how we responses accordingly. The first case came from Wuhan on 9th January, get admitted in the Sukraraj Tropical Hospital on 13th January. He presented with cough, fever, and red eye. Later deteriorated and oxygen saturation dropped, for which oxygen supplementation was given. Tested twice for influenza. Since we had no testing for coronavirus, the reagent was not available in Nepal, but we had the testing of influenza viruses. Since I was the head of influenza center, we are testing influenza regularly. So we have all the infrastructure, but the reagent, the primer and probe, which we required, was not present. So we tested, okay, he has a symptom that is similar to the influenza. Let's test for influenza, because at that time on the 13th January, you can imagine that there was a lot of countries was not reported. Only a few countries, like including China and the remaining countries, was reporting the cases. So reagent was not to us. So we said, okay, this is similar to China influenza. We tested for, and we tested twice, but he turned out to be negative only. Then we decided, okay, he's come from Wuhan University, directly from Wuhan, where the pandemic is going, where the epicenter is there, and he has the symptom. So he's a highly categories of having COVID-19. So we decided to send the sample to Hong Kong lab through the WHO. WHO helped us with the help of EDCD, NPHL, Sucrose Tropical Hospital, and WHO, Regional WHO Office, help us to transport the sample to the nearby Hong Kong lab, which is a WHO designated lab. So it was again, the report came on 23rd January as that he is positive for SARS-CoV-2. We then on 23rd January, it was declared by ministry. So from 26th January, we started testing in Nepal. Some of the supporters have delivered us the reagent, and on 26th January, the testing began. The first case we tested was the same case which sample we have transferred to the Hong Kong. So we have the sample preserved in our lab at -80°. So we tested the same sample, and that same sample came out to be positive. So we concluded the machine is working fine, the reagent is working fine, and the same test has been found positive in Nepal also. So we all are, everything is fine. Now we can start testing in Nepal. So it was 3 days after the declaration of first case. Initially, we started with the one case. Since we have only one, we have reagent only testing for ESIN and RDRP, but no positive control. That was one of the issue. You cannot imagine that some of has given the reagent, but there was no positive control because at the time the positive control was not made. So luckily someone have made in the lab this gene, designed the primer and probe and give to us. So we had only the reagent, but no positive control. So we are not sure that if we are going to run the cycle, then how we can judge the run is complete or not. Then we decided, okay, we have the sample of the first case, the positive case. We take it as a positive control and run it. Till month, we have no positive control. We are just running the first case sample, which was positive, and luckily we have collected enough sample. So we used to extract every day and then run the sample again and again. And you can imagine at that time, the fear in the social media, the picture which was coming from the China, the death rate, all the pictures, and we mainly 6 people, me included my some of the 5 staffs, they were all there. Only this much people were initially involved, and we were actually really feared because the fear was really high, because we know that this is the positive sample. We used to play with the sample. We used to extract because we have no positive control. So we have to extract the RNA from that positive sample and then run it the other cycle and other test which came to Nepal. So we used to extract the first positive sample, which was stored at -80, and use the template as a positive control. Few months we have no positive cases. Then Nepal decided to evacuate the 175 people from Wuhan. Mainly they were the student. So they were brought to the Nepal. They were quarantined at the Kharipati in Bhaktapur, and we tested on the next day. When they arrived, we tested on the next day, and everybody came out to be negative. The team, which was led by me, again gone for sample collection. Then we came back with all the samples and then tested it, and all are found to be negative. The positive control was, again, we have the positive sample of the first case, and we are running the same thing. There was one issue at that time. Many people were sick. They have the similar presentation what is with the COVID-19. But the reality was at that time, influenza outbreak was going in Nepal in the many places. And when tested, the lot of sample SARS came out because everybody has that symptom. And we tested for COVID-19, they were negative, but they were positive for influenza virus. So as the case with the symptom, fever and cough, respiratory wear, they all turned out to be negative, positive control. We have discussed about it. The symptom patients were positive for influenza. We had influenza in different places. All the cases sent for COVID-19 was coming negative, and the general public, media, expert, everybody has suspect to us that we are not able to run the test properly. And that was a big issue a big challenge for us. Because everybody is thinking, okay, only one came that was coming in Hong Kong, then there is no case in Nepal, all are having symptoms. And everybody has started to raise the question that why in Nepal means that we are not able to do the test properly. In Nepal, we are not able to conduct this very smoothly or not accurately. So it was a question from the expert, from the media, from the general public, even my director, the FNPHL, everybody was questioning. So it was a big challenge. Then we decided, okay, since we are running the sample, the positive sample, and it was coming positive with negative control also, we are used to test ourselves that has a negative control, and it comes to a negative only. So we are pretty confident that everything is fine, but also we can't stop the voice which was raised. So we decided, okay, let's but protest was continue, so that we cannot run the PCR properly. So we decided to call the WHO expert to overlook the procedure of PCR. And WHO expert came, they examined each and every steps and authorized later that everything we were running was fine and up to the world standard. So testing continued, but the sample of the first case was about to finish. Now we were shortage of the positive control. What to do? Luckily, the WHO through they provided 1,000 sample with the positive control. That was at that time the reagent was already made in Germany. The active mole company, they have sent that sample to us, and we were relieved. And after that, that contained the positive control as well as E and RDRP gene for testing of novel coronavirus. The second case then came. The case came at on 17th March. So 17th March, there was a female, young female, 30 years. She came from France, and she said that she had been found infected with her maybe close friend while in France. So she said, "I let doctor." She don't have any symptom, but she came directly to the hospital and saying, "Doctor, please check me. I have a contact with a positive patient." Then we checked her, and she found to be positive. There was two positive sample. One was the first case, one was her case, and the positive control. So everything came out to be fine. She had a city value of 16. It was very, very high. The graph which was shown was really very clear and very good. So everybody was actually happy. Although it was a bad news for the country, but everybody was happy. They're thinking that, okay, now our test is fine. We are doing everything is okay. So we declare that even the director, media, general people become happy that test is fine. The chaos started in Nepal. Chaos started in Nepal because since we declared the second case, everybody around that NPHL Teku, every shop, every people, everything is closed. Everything, if we goes to have the food into the cafeteria, everything, they all run away. So we have to, then after 4-5 days, there was a lockdown and the country-wise lockdown was initiated. So on 24th March, the country started the lockdown. So after second case, but there was one major thing was found that since the COVID cases increases, the influenza cases were decreases. Positive cases of COVID-19 started to detect. Many reagents came to as a donation from different countries, including WHO, China, India, Singapore, UAE, and Switzerland. So we have a lot of different reagents with all the gene we can test. So we have E gene, RDRP, N gene, which the CDC uses, like N1 and N3. So at NPHL, you can imagine at that time for period of time, we had everything to test. But the problem was when any physician used to call that we are suspecting as COVID-19 and we are testing and it comes out to be negative, then nobody used to easily believe, and we have to run by all the different reagents. So one test or one cycle we used to repeat 3 or 4 times, and till midnight we are in the lab only. So that was one of the big challenges at that time. When any positive case comes, we just use and if any positive case comes, then you cannot imagine the 6 people in the National Influenza Center. I mean, we used to see each other only that, okay, God, we have been infected or not, because we are handling the sample. At the time, we don't have enough knowledge that we will, the biosafety procedure were not up to the mark, because the lot of information that came to us were not up to date. We are not having all the information. Till today also, we are not having many information about this virus. But at that time, when there was a third or fourth cases, you can know the fear among the few 5-6 people was lost. Even you can detect that we used to feel that, okay, bodies, that there was used to feel the body is warm, but there was not recorded temperature. And luckily, no one was getting infected because we used to test every day. 6 staff were involved. But since this case surges and the case rises, then we started to think that these 6 people will not going to handle, and we have to train the other people as well. So we decided to train other NPHL staff for PCR and COVID-19, and then we created 3 teams. And after 3 teams was created, later on, all staffs of NPHL were involved only in COVID-19. That when the cases arises, testing we used to handle, but the pre and post analytic part was an issue for us. What happened when you get a large number of cases for testing, and at the time the prevalence of positivity were very low, but we need to give the report. The pre and post analytic part for any pandemic, when you are dealing with the many cases, that become an issue. You are testing, you have a core team, you have a technical team, you can test it, but to label that all the sample, to process in a proper way, to ensure that every sample is labeled properly, and after that to ensure that every report is delivered to the patient properties was an issue, because there was a country was lockdown. Nobody will come to get the report. You have to send the report to the person in their mobile or email or anything, or let them know. So that was an issue for us, and that becomes the issue. You have to think about not only your testing, but the pre and post analytic part, and that is one of the things that also becomes a challenge when you are dealing with a large sample. We focus on improve the pre and post analytical part. We asked other government laboratories to start testing. So in Kathmandu, there was like Dhulikhel Hospital, Bir Hospital. They already started. They said, okay, we will start the testing. And then with the help of the ministry played an important role, that all over the country, in all provinces, they started to establish the laboratories. We used to call the people in the Nepal, in the valley, the expert. We used to train them and send to the different provinces, where they goes there and train the staff, take all the facilities of the lab that can be established from the NPHL and from the ministry, and established in the different centers in the different provinces of Nepal. So means that from single test of one laboratory, today we have the 55 laboratories. Among that, 44 are the government, and around 11 is the private lab. But now the problem is that we are facing the positive rate of 10%. Means we are getting almost 1,000 to 1,200 and testing only 10,000 samples. So WHO what advice? WHO says that you have to test the samples that should be 5%. So if you are testing today, at present we are getting 100,000 cases, so we should be testing at least 20,000. But the bad luck, or say the worst part, is that we are testing only half of the sample. So that is a big challenges. We have to increase this testing, because 10,000 at present rate of positivity is not enough, not enough, not enough. That you have to understand. We need to double our capacity. Initially, PCR test was started from NIC and PHL Kathmandu, then spread to different provinces. I have already discussed about it. But there, in the past, there was one thing, that since there was testing only available in Kathmandu and only to the 1 or 2 centers, the government, and at that center, we are not able to increase the PCR testing. And that is the problem everywhere. When you start this anywhere, you will face the problem that you cannot begin the testing at once as 1,000, 2,000. So at that time, government decided, okay, let's bring the RDT to increase, to save their ass, or to increase the testing. So they bring RDT, and that was the antibody-based RDT, and that was a big mistake. Actually, at that time, which was the antibody-based rapid diagnostic test was an issue, and they should not bring at that time. That was actually useless thing which was done, because when people get a false negative, if I'm a positive but I got a report as a negative, then my confidence of going in the community will be high, and I'll be a source of transmission to the community. So that is a big issue. We should not be practice anything that will lead to the false negative report. That is one of the things. And there was again another issue of bringing this point of care PCR machine. So that was again came from the China, and they were also giving the false negative report. The machine was not correct, and that again helped in spreading the virus in the community. So since only government lab were testing, so there was again the problem of backlog of the sample. So few test centers were there, the samples were huge. We used the turnover times comes from 3 to 7 days. Then that was also a big challenges. So we started to increase the lab, and lab has been increases from the single to 55 lab in the country, with 44 government and 11 private. So that is all about testing what we did in Nepal since January 26 to till now. Thank you.
Okay, thank you, Dr. Ranjit Saab, for your elaborative presentation regarding the scenario of COVID-19 screening system at NPHL. And we will have the questions answer session at the end of this session. So now I would like to move to our second speaker. I would like to request Dr. Sam Dumbre for his presentation. And Dr. Sam Dumbre has been working as assistant professor at the Institute of Tropical Medicine, Nagasaki University, Japan. His primary research interest is in the understanding of tropical infectious disease, especially the viral diseases. His group is also working on different projects related to COVID-19, from vaccine development to public health perspective. And we will welcome him with his presentation related to COVID-19 crisis, research on vaccine development to public health perspective. Dr. Sam Dumbrisi.
Yeah, just a moment. Can you hear me?
Yes.
Good morning, everybody. My name is Dr. Sam Prakash Dumbre. Thank you for very nicely introducing me. In today's talk, I'll be talking a little bit about the current progress in COVID-19 crisis, especially in the vaccine development and other public health activities. And I will also highlight some of our research activities that we are currently doing in our institute in collaboration with several organizations in Japan and other countries. I don't want to go in detail for this slide because Dr. Ranjit already highlighted on the burden of this disease. As we know that in Nepal also now the second wave has come and a lot of problems is there due to the mortality and the infection rate, so as in the other countries. So this virus is very peculiar compared to other viruses. And as we see how two travelers from Wuhan can make a big cluster in churches and in other public areas and make a huge expansion of the infection and transmission. And in the left side, you can, in the right side, you can also see that this virus, how this virus was, how this virus was spread from Wuhan to Europe and to throughout the globe, and even in the developing to the developed countries, equally affecting. So to combat against this COVID-19 pandemic, until we have an effective vaccine or a specific drug is available, there are basically three strategies. The first is to stop the entrance of the infection into the country. And the second one is to prevent the transmission. That is, we try to reduce the R0. And the third one is enhancement of the clinical management. For example, in Nepal now, we are already passed through the stop entering the infection. So we are in the active transmission stage. That means we have to have strategies like counter cluster activities, contact tracing and testing, social distancing, and other preventive measures like masks, hygiene, and quarantine and isolation strategies. And in parallel to this, we also have to focus on the enhancement of the clinical management because in our country, still we have limited number of hospital beds, limited number of like ICU, ventilators, and all this health management, healthcare system is not up to the level. So we have to have it expanded and we have to have it strengthened in terms of all the necessities. Of course, science has helped a lot to fight against this pandemic. For example, we have now cutting-edge science, so we can get the fastest identification information of the virus, and we know the genome sequencing that help in the vaccine development, diagnostics, and all sort of preventive activities. We have a huge data repository available, and we have a very good data sharing system. Now, a lot of clinical trials have been ongoing. Like more than 1,000 trials are ongoing in therapeutics and vaccines. This is all due to the latest development in science and technology. And we also have a real-time progression information of the disease and epidemiology. This is also helping how the disease is moving from one place to another place and how fast it is moving and how to tackle them on time. So the first is to flattening the curve. As we all know that when we have the static level of the healthcare capacity, then only the mitigation way is we have to apply a lot of other preventive activities so that we can flatten the curve. If we don't have that a high level of healthcare capacity, then we have to gradually also increase the healthcare capacity to flatten the curve. So that this two-way, either way we can do, or sometimes we have to apply both the strategies to flatten the curve. And if we don't have this kind of adequate mitigation strategies, we definitely have a resurgence of this curve, like secondary curve, second curve, third curve, like this, for which in Nepal, for example, we have the second curve. I skipped that slide. So now we have to go to the new normal strategy. Until we have a good vaccine, we have to be perhaps stay with the new normal until 2022. We don't know. That's why COVID-19 pandemic has significantly changed the way we live. So we have to have now business. We have to have our business. We have to have our all the activities in a different way. That is, we call it new normal. For example, work from home and digitalization is very common now. Yes, due to the huge political, economic, and social and technological environmental impact of COVID-19, we definitely need to go through the new normal. We cannot stop everything at all. So we have to anyway go through that, and we cannot go back to the way we used to think, the way we used to work. We have to find a new way. And to go to the new normal, we have some of the strategies. For example, Japan has been doing the 3 C's, like closed space prevention, prevent to go into the closed spaces, crowded spaces, and close contact settings, something like that. This is something very simple, but we can apply in developing countries strictly, and this will also help us to go to the new normal activities. Another most important part is the COVID-19 vaccines. If we have a vaccine, of course, definitely we can have a best remedy for this crisis. And now a lot of vaccines candidates are in clinical development. Some of them are already in a phase 3 clinical trial, and some of them are in phase 2, and a lot of other candidates are in the preclinical development. And majority of these vaccines are adenovirus-based vaccines. And of course, there are also some issues with this kind of vector-based vaccines. And there are also some novel vaccines like RNA-based vaccines are also under development. Some of these are already in the phase 3 clinical trial. And nearly $10 billion investment has already been secured for this vaccine development. And interestingly, more than 9 billion is alone by the US government. So this is just to show you the sketch of this COVID-19 vaccine pipeline platform. As I already mentioned, there are different vaccine platforms available like vector, mRNA, DNA, protein subunit, and others. Most are vector and mRNA vaccines, and some are also the inactivated virus vaccines. These are the areas where clinical trials phase 3 are ongoing with a lot of enrollment, more than 30,000, 50,000 enrollment based on the different vaccine candidates. What we are doing in COVID-19 currently, let me highlight some of the activities that we are doing. We are working on understanding the viral genomics of SARS-CoV-2, like whole genome sequencing and clinical perspective. This is, we have already done in Vietnam, and I'm also supporting in Nepal for these activities. We're also working on vaccine development activities, and also we have a little bit of drug development activities in our lab. And we are also, apart from these basic science activities, we also have other activities like particularly focusing on the more public health approaches. For example, we did healthcare workers preparedness for COVID-19. It's a global study. It's a very big study with 376 hospitals throughout the globe with from 56 countries. And we also conducted an upper limit of countries' health capacity and how it relates to the overburdening of the disease in the pandemic time. We are also conducting another study, a medical declaration study. With this, we can find out the cluster of the COVID-19 cases on time using the community network analysis. And we're also working on a super spreader study, as we know that some of the patients can be super spreader. We don't know who is the super spreader. And so there is some way that we can find out the super spreader, and we can timely find out the super spreading activities, and we can mitigate the problem. And we also do some psychological impact of the people under quarantine and isolation. This is also a multinational, multi-country study. And we're also working, actually we finished the last one that is about the universal checklist of the COVID-19 control measures. That is, so we use the Delphi study strategy. In the understanding of the viral genomes, we did it on the in Vietnam, and we actually finished the whole genome sequencing of 32 virus isolates. And we did the very first 2 virus isolates from Vietnam, and that was from a father and his son. And very interestingly, the virus, based on the virus isolates of the father and the son, the clinical characteristics was a little bit different. And also not only the clinical practice, when we isolated the virus, the in vitro activities in the lab was also different for these isolates from the father and the son. And in the interventional studies, as I mentioned, we are doing a vaccine candidate development. We applied a relatively new strategy, that is the mRNA-based vaccine. And we are using the lipid particle to deliver this vaccine. And we have a specific strategies for the vaccine delivery. And also, we are already done with all the in vitro studies, and the animal studies results are also already available, and we're analyzing them, and they're quite good. And we are planning for the phase 1 clinical trial soon. For the drug development part, as we have been doing a lot in the, not only me, but my colleagues, they have been doing a lot in the traditional medicine and herbal extracts. So this time I'm also involved in some of these activities, and we are doing this extract and the traditional medicines to look for if they have some antiviral activity for this SARS-CoV-2. The first hospital staff preparedness study, we enrolled 17,000 healthcare workers throughout the globe. And we found that the level of awareness and the level of preparedness was disproportionate according to the country, according to the level of the education and other profession and all these things. And they are, in overall, they are good, but still not adequate. So we really needed to work on it. And we submitted this paper into Lancet Infectious Disease, and it's on the review now. I don't want to go into detail of these results. And this is, I think, one of the very interesting study we have done. We try to find out what is the country's upper limit of the country's capacity and how it overburden the disease. For example, as we know that the curve, to overburden the curve or to mitigate the curve, the healthcare system capacity is very important. So if we can know that when the number of cases reach to this level, the country's healthcare capacity is overburdened, then we have some idea when to do what, when to apply what kind of mitigation measures. For example, this is just an example. I don't want to go in detail. It is basically based on the total number of active cases and the mortality rate. At some point, the active number of total cases and the mortality curve meets, and based on this one, we can find out the upper limit of the health capacity of a country. And this is very good. We can see the very good relationship between the upper limit of the active cases and the ICU upper limit of the cases and the mechanical ventilators and cases and hospital beds and so on. So this is very interesting, very important. We did it for 35 countries, and unfortunately, we have not yet finished with the data from Nepal, because Nepal data was not completely available by that time. So we are also doing on it. And for the medical declaration study, this is just to find out, early find out the cluster. When there is a cluster, how we can find out this cluster. We simply use a network analysis, and then we can detect where the cluster is coming or where the cluster is forming. The psychological impact study is very common. I think most of you are very aware about it. And we have done 2 studies for this one. One is the pre and one is the post, like post-stress trauma study. And this is also multi-country, multi-center study. And we just finished the data collection, and we are now analyzing the data. And this is one of the ambitious study, I would say. In this study, we try to find out the universal control measure checklist for the COVID-19. And because in the different phase of the pandemic, a different phase of the outbreak, there are different strategies applied for the mitigation, for the control of the disease. So we try to find out if we can, because many countries are using many different strategies, many countries are using many different control measures. So we want to find out whether all these are good or not, whether we have to follow all whatever others are doing or not. For that, we try to find out a universal checklist for the control measure of this COVID-19, and we have just finished this one. And we have, I don't want to show all the results here because we don't have enough time. So we have just submitted this paper into Annals of Internal Medicine. Yeah, this is about the super spreading event, and we try to find out using some analysis. It's a very simple questionnaire-based method, and using this one, we can find out the super spreading events where it is occurring and how to tackle timely on that super spreading event. So the take-home message is, with this COVID-19 crisis, of course, it's a very massive problem and it's a big disaster for our generation. But there are a lot of opportunities to, a lot of scientific studies can be conducted in Nepal, for example, too, particularly in the public health approaches, which help in making decisions on moving towards the new normal. And the very interesting part is that we can do in the North-South collaboration. For example, people who are working in the developed country can collaborate with the developing country so that the capacity of the developing country can be enhanced. This North-South collaboration is really helpful for the developing countries as well as for the developed country, because they can get a lot of data and a lot of work done in the samples in the developing countries. And as well as we can do the South-South collaboration for the exchange of technology, information, and some things like that. With the international collaboration, we can do like not just the public health approach. We can do a lot of basic science studies, from basic science to intervention like clinical trials, and all these things we can do. This is, I would say, this is an opportunity, as Dr. Ranjit already said, that we have a lot of laboratories, PCR-based laboratories now in our countries. Previously, we never had this kind of advocacy of the PCR lab. We rarely have few PCR labs. So this can be utilized for other infectious disease in the future also, and other diseases also. This is something like a capacity building. This is an opportunity also. With the available evidences globally and in Nepal, the country has to discuss on flattening the curve, moving towards new normal. And of course, the final key is the strengthening the local capacity, and with the collaboration with North-South and South-South collaboration, I would say. And the key is to stop this prevention, to flatten the curve and to get it into the normal life or new normal. We really need to have a very collective response. I just borrowed this slide from somewhere. I think this is very interesting. With this, I would like to end my talk, and I would like to acknowledge these people who have been involved in this, all of these activities. Thank you so much for this time. Thank you.
Okay, thank you, Dr. Shyam, for your excellent presentation. Now I would like to move to our next speaker. I will request Dr. Dinesh Rokhaya. So Dr. Dinesh Rokhaya is he completed Bachelor of Dental Surgery from Nepal, and he has completed his PhD in Dental Biomaterial Science from the Faculty of Dentistry, Thailand. He is currently a faculty member at Walinkak University International College of Dentistry, Thailand. He is involved in both clinical and research activities in oral health, prosthetic dentistry, and dental biomaterials. And today he will be presenting about the impact of coronavirus disease in dentistry and dental treatments. To you, Dr. Rokhaya. Yes, Dr. Rokhaya, can you hear me?
उहाँको माइक्रोफोन म्युट छ जस्तो छ।
Dr. Dinesh, can you?
Hello?
Yes, Dr. Dinesh.
Yeah, can you hear me? Hello? Yeah.
Yes.
Yes. Thank you for inviting me to talk on dentistry and COVID. So today I'll present about impact of coronavirus disease in dentistry and dental treatments. So from previous presenters, they already mentioned about the COVID-19 and the origin and about pandemic. As you know, it has spread globally and causing a lot of problems worldwide. At present, COVID is still increasing in many countries, including Asian countries, and has influenced every aspect of life in worldwide. In dentistry, COVID has profoundly affected the oral health deliveries and service, and especially the dentist, patient, and dental assistants and, and other accessory personnel are all affected. So the basically the origin, the lungs and the oral cavity are the ecological, commensal, symbiotic, pathogenic organisms. So you can see there is exchange of microorganism between the oral cavity and the lungs and allowing the healthy microbial distribution. But when the equilibrium are altered, it can cause the illness due to the overgrowth of microorganisms and causing the infection in the lung. And lower respiratory tract is initiated from the inhalation of microorganisms from the aerosol droplet or by aspiration of oral secretions with the oral disease, from the oral diseases, like containing the various microorganisms. And recent studies also found that the salivary gland, it also act as a reservoir of virus, and which can cause the infection to the lung. And COVID-19 can be transmitted by the infection which can be originated from the saliva. And another study also found that cytokines from the periodontally disease tissue can infiltrate the saliva through the gingival circular fluid. So this is the fluid present in the mouth and can cause inflammation or infection to the lung. Okay, you can see in this figure how the cytokines, they are released from the periodontal disease, from the oral disease, and can cause infection to the lung. Okay. And in dentistry, there are two main common diseases. One is periodontitis, which is related to the gum, and dental caries, which is related to the teeth. So these are common oral disease associated with the imbalance, can cause the imbalance of bacteria in the mouth. And another problem is inadequate oral hygiene can also increase the risk of bacterial exchange between the mouth and the lung, okay, and can cause the serious infection. And this is especially more in case of diabetes, hypertension, and some cardiovascular diseases. So transmission of COVID in dental clinic. Right? When the patient come for the dental treatment or you go to the clinic, right? If the patient is infected, so it can cause the infection and it can contaminate the some instrument or dental chairs in the dental clinic. And when you do some dental treatment, the instruments from the aerosol and the droplet it can also spread and cause the airborne, and it can cause the infection to the other individuals, and it can also infect the other dental profession or the other patients. And another problem is when the patient come for the treatment or you go for the treatment, right? And if the infection, if he or she has infection, then the instruments can also are infected. So the improper sterilization can also transmit the virus. So this is important. The sterilization is very important. And the main cause for the transmission is the aerosol generated from the, especially the during the high-speed drills while the cavity preparation of some doing fillings. So the dental treatment should be done with high standard of care and infection control. And you can see now there are many guidelines, they are released from various parts of the world, especially like these are the common big institutions like Faculty of Dental General Practice in the UK and FDI, World Health Organization and CDC. So this all they give guideline during the dental treatment. And this is from the FDGP. They divided guidance into 5 parts, like pre-appointment, like before the appointment, you how to take the precaution, and patient attendance. When the patient reaches the clinic, they should take the precaution, and during the treatment. So what all precautions should be needed during the treatment and after the treatment also. And this is the management and governance tasks. So these are the risk assessment of the staffs. In Nepal, the Medical Council, they also released one guideline along with the Nepal Dental Association. The aim was is to allow the dental practice to be resumed all level of highest standard of safety to the patient and the safety of the staff and dental professions involved in the treatment and prevention of COVID-19. So basically, they also took reference from other articles. These are some conclusions. So when the patient go for dental treatment, so the symptoms are to be checked, and if the patient is suspected positive, so they should be precautions should be done, like the screening, chest X-ray. Actually, this should be referred to the hospital, and they will do the necessary screening and treatment. And if the treatment is not urgent, so we can defer the treatment for the 2 weeks until the COVID is treated. Or if there are some urgent treatment, right, acute swelling or pain, so there should be pharmacological management should be done. And when the patient is negative, so we can do some treatment with precautions. And if there is too much emergency, so we can do in the airborne infection in the proper isolation. So this table show the various treatment urgencies in the dental practice. So there are like emergency, urgent condition that are managed with minimal invasive procedures, urgent condition that need to be managed with invasive and aerosol generating procedures, and these are non-urgent and elective. From this, we can see that if the patient is treatment is too much severe, like a fracture or some severe pain, these are to be managed with emergency. But other like severe pain less than 7 scale, or from the fracture, some tooth, these are like urgent condition requiring minimal invasive procedures. And there are some other treatments requiring the invasive procedures, so like the severe dental pain, or especially from the fracture of vital tooth. And these are the non-urgent, like if you want to do the recheck of some denture or fix some denture treatment or some aesthetic dental procedures, so these are to be can be deferred. And the WHO Centers for the Disease Control and American Dental Association, they all made some give some guidelines. So these are the brief. So the treatment should be done with protective equipments, PPE, and hand hygiene should be maintained. And they advise to use the N95 mask. As you can see in the figure, all necessary precautions should be taken by the patient and the staff. And especially before doing any treatment, it is necessary to rinse with 0.2% povidone iodine or 0.5% to 1% of hydrogen peroxide to reduce the virus in the mouth. And it is always advisable to use the disposable instruments, so you can use and throw. And it is also advised, this is rubber dam. So while doing the dental treatment, you can use the rubber dam to cover the nose, and you can expose only the treatment part. So if the treatment is done in this tooth, so you can expose only this tooth and do the treatment. But this is not, this cannot be done in every type of dental treatment, but whenever possible, the rubber dam should be used. And it is always necessary to reduce this three-way syringe, because it can help to spread the virus. And dental treatment of suspected and confirmed cases, like it should be done with airborne infected isolation room. So this is like proper treatment. When you are going for the dental treatment, patient and the staff should be take the necessary precautions, so to prevent the spread from patient to the health workers, or from dentist to the patient. And another important is oral hygiene should be maintained, because it also helps to transmit the virus. And this is one study we recently did in Nepal, an impact of COVID-19 on dentists, dental practice, and patient in Nepal. So we did online survey in 406 dentists in May, and to check the assess of impact, how the it is impact. So we did, and 60% were the female dentists, and these are all the age group. Maximum was from 25 to 29, And you can also see most of the dentists, they work in private clinics. You can see 40%. So 40% they work in private clinic, and we can see the awareness, knowledge and awareness was quite good, and they are aware of the precaution taken during in the clinic. And you can see only 10% of the dentists were doing the treatment during the lockdown. Actually, this was study was done during the lockdown, and they are quite facing the financial burdens. And many of the dentists, almost 60%, they were not receiving salary also. So this is a quite burden for the dentists in Nepal. And mostly they defer the treatment, and they are doing only the emergency treatments. And these are the time spent during the dentist. So most of them, they spend during with the family and relatives. And some they did research work and some other works also. And this was the conclusion from the study. Like most of the dentists work in clinic, and the patient were receiving only from the 10% of the dentist. And high number of dentists were affected by the financial burden, and they think 80% think that they should do the treatment, but only 25% think that they should do in emergency treatment only. So another study brief, this was done by my senior in Dhulikhel Hospital. They did the incidence and pattern of dental emergency during the COVID-19 in 150 NMC registered dentists to check out the nature of the dental emergency during the first month of the lockdown. These were similar to our research. They found that 50% work in the clinics. So they work in hospital, colleges, and some government centers. And these were the type of the treatment. So they did virtual and both. So virtual means by online consultation and video conference. And these were the various emergencies. Like you can see the pain was the main common cause of dental treatment, and swelling, then followed by trauma and simple orthodontics and TMJ pain, trismus, like this. So you can see the pain was the most common patient coming for the treatment. And they found that from the previous slide, you know that dental pain was the common, and followed by swelling, trauma, and broken appliance. And they also found that the virtual dental consultation is gaining popularity due to the COVID, and in Nepal also. So Nepalese dentists are going to change the way of dental practice because of COVID. So they are slowly changing. And this is one important slide I took from American Dental Association. They found out what the dentist will do if the current restrictions last until. So they found that you can see the graph. They will find an innovative way to expand the patient base. So they have to change the way of the practice, and another little bit more percentage they find the innovative way to lower the operating costs. So many clinics were closed, so they are finding the way to lower the cost of the practice. Okay, and a huge number, look, around 70% like this, they found. They also want to borrow the money and address the financial faults. So it was quite burden for the American dentist. And another group, they found that adjust the staff salary. So they will adjust the salary of the staff to maintain the cost. And you can see very few, almost end of August, you can see that I do not think I can sustain my practice. So this suggests that a huge number are facing financial burden even in US. So final conclusions: dentist, patient, and the dental assistant and dental practice are severely affected from the COVID-19, and because of infection risk associated with aerosol generated from the high-speed drills, the dental treatment should be done with high standard of care and infection control with proper recommendation from the proper institution. And it is always important to maintain the oral hygiene, because due to the risk of transmission, exchange of virus from the mouth to lungs, and improved oral hygiene may play important role in reducing the complications. These are my references. Okay, thank you.
Thank you, Dr. Dinesh, for your excellent presentations regarding oral hygiene awareness and lung infection, along with the dental practitioners' issues at the COVID-19. Now, we will have some questions, answers regarding our first session of the presentations. So I would like to pick a question from our viewers, and we found one question from Suresh Panthiji, and I think this question is for Dr. Ranjit Shah. So I would like to just read the questions read by the Suresh Panthiji, and we will have a discussion in this just for the 10 minutes, because we are already running out of the time. So I will just request Dr. Ranjit to answer the questions. And the question is, if we see the result from some laboratories, the positive rate is about 50%. How are we going to handle it? For example, we see the report of September 13 at Provincial Laboratory of Province 5, when 170 samples were tested, 90 were negative and 80 were positives. So Dr. Ranjit, I would like to address you this question.
So thank you for the question. Actually, this scenario can happen, and this is common at present time, because if you see the, I'm not talking about that your scenario. I'm talking about the hospital scenario. If you are look at the hospital samples, they are coming out around 50 to 60% positive. So if you are in a lab, in a private lab or government lab, but you are getting a positive sample from the hospital. So in hospital, people who are infected, who have the symptoms, they are only going. And if we are screening among them, then we will get 50 to 60%, and that we are getting actually. Regarding your question, your scenario, yes, we can get that scenario in some situation. If there is a cluster of people getting infected, so if a sample comes from one community, and if there is a widespread spread in that community, so we are getting the sample that is from contact tracing. So the people are there, they are infected, their known people are also, surrounding people are also infected. So in that scenario, you can get the positivity rate high. Although we have at present as a whole country wise 10% positivity rate. But from a particular lab, if we are getting around 50 or 60, we have to think that the sample are coming from the cluster where there is a widespread in the community.
Okay, Dr. Ranjit, thank you so much. I would also like to request our session chair and co-chairs, if you have any relevant questions regarding our first session. If you don't have any, then I would like to move to the second one. Dr. Ranjit, Rojit and Dr. Suman, do you have any questions?
I have one question for Dr. Syam. So you talk nicely about the ongoing project on the vaccine. So can you please briefly elaborate on your universal control measures and measures checklist for the and its applicability? Dr. Syam? Dr. Syam, are you there?
Yeah.
Yes.
Can you hear me?
Yes, now, yeah.
Thank you, Dr. Rojit, for this opportunity. This is the universal checklist is about, basically in many countries, they use different strategies. For example, in Japan, they use some sort of strategy like 3 C's. And in some countries, they even use the, sanitizing the money, and in other countries, they are using like strict lockdown, and some countries, they did not prefer that one. And some countries use, if you do not use the mask, they will punish, if you use the mask, it's okay. Or some countries use, okay, they just recommend. So even the same measure is used differently in different countries. So what is the optimal optimal control measures, so that we can actually no need to have, follow all the strategies, every strategy and everywhere? What could be the best one, or what could be the universal one? That's why we design and a study, and we use 19 experts in the field of infectious disease, especially in this pandemic and previous pandemic also. So those people, using those people, and we make a set of some specific questions. First, we collected all the control measures throughout the world, every country what they used, and then we made the scoring system for all these control measures, like 0, 1, 2, 3, 4, something like that. And then we made the big checklist, and after scoring them all, and we sent it to the experts for their views, And then based on the views, we again, second round, we did the, this is called the Delphi study. We did the revision again, and then some we deleted, and some we added, and some we have to re-score them. And finally, we have a very nice structured control measures universal checklist, which has also the scores. So, and based on that scores and the geographic region, so we can decide that which control measures are best suited for this region. So we develop this the checklist. This is for the application in any countries, and based on their applicability, they can use it, and they can follow the scores, and they can decide, okay, we can use these control measures to control, and which stage of the outbreak also they can decide from that checklist. So I hope this will be available very soon in the journal.
Thank you. Thank you. If possible, I'd also like to ask one question for Dr. Ranjit. Is that okay?
Yes.
Okay.
Yes.
Dr. Ranjit, yeah, so you presented very nicely about all the scenario that has we passed from the past 6 months. So I think Nepal has made a significant progress in the molecular testing. That is really, really appreciable, because from the time we don't have even a single laboratory, now we have almost more than 40 laboratory throughout the country. So my question is about how we are progressing on the rapid or point of care testing, molecular testing for this disease. How can we progress more to properly utilize this facility? And also, how do you think that Nepal can implement the rapid antigen test in the coming days?
Okay, thank you. Really a relevant question. Actually, we have developed many labs. You have mentioned that 40 labs for testing of the molecular testing of coronavirus. But regarding the point of care test, there were some machines that came to us, but it was not up to the mark. The result which we are getting from the around 45 minutes or 30 minutes molecular testing point of care PCR machine that was donated from the China and Tibet, that was not found usually good, because the result were not convenient with the, when we compare with the original one, that we didn't get good result. Regarding how we can utilize it, there are a lot of this TB PCR, that is gene expert machine, all over the country. Around 80 centers are there. So that center can be utilized if we get the 30 days best PCR that is available, and that is have a sensitivity and specificity high, very high. But the problem is we are not getting the 30 days enough in our country. Some of them they had tried and got a 5,000 around from USA, but since this is made in USA and USA government are not releasing this cartridges, so we are having the issue. If we can bring that cartridges in Nepal, then all this gene export machine can be utilized. And if you calculate that one single gene export, that can be 2 to 4. So we can develop a lot of in the remote places. This molecular based testing can be assessed. So that is one of the point where we have to work, and that is actually not been worked very well. Another point is antigen-based testing. Antigen-based testing have been brought in Nepal. There are many private, although we have not officially widespread use have been given, but there are sub-centers that are doing it. The issue is that the sensitivity and specificity. The sensitivity we are finding is 60 to 80%. So it is wise to use at this present of time is a question, because we are not getting the about company. We are getting from Chinese companies, some ST power sensor. Sorry for mentioning the name. I have no any conflict of interest with that. But since this company, we are finding that the positive rate, what they have mentioned in the packet insert, but really what we are getting is a totally different. We are getting, even all the international scientists are reporting that they are getting just like a flipping the coin. If you are flipping a coin and saying that positive or negative, and if you are going the antigen based RDT as a 50 or 60%, that is similar to that flipping a coin. So that will create a disaster, because if again if a person with a false negative report is roaming in the community, then they will spread the disease. So we have to actually think very wisely, and we should apply this antigen based test only to the patient who are coming to the emergency department with symptom. Actually, what I have found when I have was working with the kids, then found that the CT value which have below 30 are coming positive, are detected by that kit. So the patient who are symptomatic and viral load will be detected around 90 to 100%. But above 30, which city value and viral load is less, they are going to be missed out. The benefit is that the city value less will be detected, means they will not be spread the disease. That is one of the benefit. So we have to think about it. It can be a good option, but mainly at present we should focus on the emergency department, patient with the symptoms, and that will be a better decision for now. Thank you.
Thank you, Dr. Rojit. Thank you.
Yeah.
Can I ask
Yes,
one question to Ms. Sam Dumresha? Just one question. I want to know that is a vaccine available? What you are preferring the vaccine trial in Nepal or not? If you are, then what will be the appropriate vaccine? It will be a Russian or a Oxford one or some Indian or Chinese? What is just a simple answer? What we should go through? Because it is an issue that we should go through that trial or not. If yes, then what will be the appropriate and ideal vaccine we should go for it? So you are mute. Can you unmute yourself?
Yeah, I'm mute. Sorry. It's a very relevant question. And regarding the vaccine trial, I also attended one meeting previously in the Ministry of Health. I think there are maybe it's too confusion. Having vaccine trial and having vaccine is something different. Many people confuse with this idea, because having vaccine trial is we are just doing some study in the country. It doesn't ensure that you will get the vaccine. So that is the two different thing. I think many people are not maybe going through. So yes, I would say we need to do vaccine trial. I would go for the vaccine trial, of course, because it will definitely, it will not ensure the vaccine availability, but it will definitely increase the capacity building in the country, and our trial capacity will be strengthened, because we are very poor in the vaccine trial activities. So this is a good opportunity for us to go for that one. I think I would definitely suggest to go for the vaccine. And side by side, we are also at this time, because a lot of vaccines are in pipeline side by side, we also have to think about how to ensure the accessibility of the vaccine. So the government has to make a very serious dialogue on this part. And if you ask me which vaccine, of course, we as a scientist, we have to think about the data. So for example, just few weeks ago, there was no data from the Russian vaccine, although they claimed a lot of this and that. But yes, we know we have to based on the data, and based on the current data, I would definitely go for the current AstraZeneca vaccine and the Oxford vaccine, because it's in the current phase 3 trial. And although we don't know the result yet, but these 2-3 vaccines are the most advanced. And for the for the vaccine transport system also, this is much easier than the RNA-based vaccines. Until we have the stable RNA vaccine transport system available, that can be another issue, because we need to have a very low temperature system available. So I would go for this vaccine without making any personal preference, but based on the data, I would say that. I think I could answer it.
Okay, thank you, Dr. Shyam. We are a bit late in the sessions, 15 minutes late. So we can have the discussion session at the end of the session, the question answer session at the end of the session. So I would like to go for the second session. So now I would like to move to our second part of the presentation. And this session, we welcome researchers and the students who are the future researchers in the field of medicines. We will hear the interesting stories from their research, what they are doing in Nepal or abroad. And before moving to this session, I would like to remind our presenters to be very precise about their time, because we are already running late. So I would like to request, I would like to invite Ms. Niti Shrestha for her presentations. And Niti Shrestha, she is a registered nurse from Nepal, and she graduated from Kathmandu University. She's working at the Sahid Gangalal National Health Center. She is highly interested in research activities, and her articles are published in different journals of Nepal. So I would like to request Ms. Niti Shrestha for your presentation.
Thank you, Ms. Indira Tiwari-ji, for such an overwhelming welcome and introduction. And hello, all the speakers and all the Nepalese who are watching this first NRNA Asia Pacific Knowledge Convention via Facebook Live. I'm Niti Shrestha, and I'm currently working in Sahid Gangalal National Heart Center. And the topic of my presentation is Children with Cerebral Palsy and the Quality of Life in Nepal. Cerebral palsy is permanent and non-progressive disorders which occurs in developing fetal or infant brain. It affects both movement as well as posture that results in restriction of activities. And quality of life is individuals' own perception of overall well-being and contentment in life. It includes both social as well as health-related domains. Lots of research indicates that in compared with econometric peer groups, children with CP have impaired functional as well as psychosocial quality impaired functional as well as psychosocial quality of life. Moreover, pediatric CP literature also suggests that different comorbidities like visual, hearing, and feeding impairments and language delay and epilepsy may be associated with decreased quality of life. As per the surveillance that is conducted by Europe, the incidence of cerebral palsy is 2.5 children per 1,000 live births. And also a population-based study was conducted around the world, which indicates that the prevalence of CP ranges from 1.5 to more than 4,000 per live births. And the objectives of my study were to assess the quality of life of children with cerebral palsy, to assess various domains of quality of life with children with cerebral palsy, to assess quality of life as reported by child versus quality of life as reported by caregiver, and to find out the association between cerebral palsy related factors and quality of life. In our study, socio-demographic variables and cerebral palsy related factors were included as independent variables, and different domains that measures the quality of life were included as dependent variables. And among 7 domains, 2 domains, that is access to services and family health, were asked to only caregiver, and remaining 5 domains were asked to both caregiver as well as child. And the cerebral palsy related factors includes types of cerebral palsy, severity of cerebral palsy, presence of comorbidities, and age of diagnosis. We use descriptive cross-sectional study design, and by using purposive consecutive sampling technique, all the children who were diagnosed with cerebral palsy and registered in self-help group for cerebral palsy Nepal, aged 4 to 12 years, were interviewed. However, the child with severe mental retardation were excluded from our study. And for the statistical analysis, we use descriptive statistics, that is frequency, mean, and standard deviation, to interpret the results of socio-demographic variables and cerebral palsy related factors, and Kruskal-Wallis and Mann-Whitney to find out the association. As per our study, this chart shows the socio-demographic characteristics of child as well as caregiver. The mean age of child was 8.35, and 59.5% of child were male and 49.5% of child were female. And the mean age of caregiver was 21.5. Similarly, majority of the caregiver, that is 88.1%, were female, and the mean age of diagnosis was 2.9. This pie chart shows the types of cerebral palsy in percentage. More than 50%, that is 62%, had spastic cerebral palsy, and more than 1/3, that is 31%, had dyskinetic cerebral palsy, and only 2% had ataxic cerebral palsy. And this table too shows different domains that measures the quality of life. And this chart depicts that the mean QL of child with cerebral palsy as reported by child was 176, and the mean QL that is reported by parent was 62.47. Both the child as well as parent gave high score to social well-being and acceptance and emotional well-being and self-esteem. Similarly, low score was given to pain and impact of disability by both child as well as parent version, and low score was also given to access to services and family health by parent. This depicts that overall quality of life is fairly good, and psychosocial quality of life is better than physical quality of life. As I have mentioned before, child with cerebral palsy have good psychosocial quality of life over physical quality of life. And due to the time limitation, I have not included about the association, but as for our study, severity and age of diagnosis were strongly associated with impairment of quality of life. and quality of life reported by child was better than quality of life as reported by the caregiver. Now to conclude our study, quality of life of children with CP is fairly good with regards to the different domains that we analyzed in the study. And similarly, the caregiver perception of quality of life of children was rated low than the perception of children. This might be also due to the excess care burden that is faced by caregiver. And children with cerebral palsy needs more attention and perhaps the better opportunities. And government also should foster child health services for such cases. In our country, like Nepal, there are only few centers that focus on the improvement of the physical capability of child. Government should establish more centers which focus on the physical capability of the child, and this should be equipped with different specialists like physiotherapists, speech therapists, hearing therapists, that because of which the improvement of physical capability of child with CP is possible. And since the low score was given to pain and impact of disability, it suggests that there is more need to manage the pain among the children diagnosed with cerebral palsy. Due to the small sample size, this study can be used as a pilot study for other prospective as well as case control studies so that the results will be more generalizable. And my acknowledgements to Dr. Ritesh Thapa and Ms. Savitra Paudel, who is also the co-authors of this study and who helped throughout the course of this study. And similarly, my acknowledgement to all the children who participated in my study. Thank you.
And our next speaker is Professor Ram Vinod Mahato. Professor Ram Vinod Mahato is professor in Tribhuvan University Institute of Medicine's Ayurveda campus and teaching hospital, Kirtipur. His research is mainly focused on diabetes, neuroendocrine reference interval study. So I would like to move to you, Professor Ram Vinod Mahato. Are you ready? Professor Ram Vinod Mahato. So I think Professor is not here. Professor Mahato is not here. I would like to request Saraswati Paudel.
Hello.
Saraswati Paudel.
Hello.
Yeah, okay. Professor Ram Vinod Mahato is here. Okay, you can continue with your presentation, Professor.
Okay. Namaste. Namaste, Indira ji, Dr. Rojit, Dr. Suman, and everybody. Thank you very much for introducing me nicely. I am not a professor, actually. I am assistant professor here.
Okay, sorry for that.
Okay, anyway, thank you very much. I'm going to discuss little about. Are you hearing my slide?
We cannot see your slide, Professor.
Okay.
Yeah, we can see it now.
Okay. Are you seeing the slide?
Yes.
Okay. I will discuss little about establishment of reference interval for common biochemical parameters for Nepalese population. Actually, the word reference value was first introduced in 1969 by Ralph Grasbeck. Normal values and statistics was the first study on the topics. Later on, it was realized that the term normal values was incorrect. So the term reference intervals came into use. Between 1987 and 1991, IFCC, that is International Federation for Clinical Chemistry and Laboratory Medicine, published 6 articles and recommended that each laboratory must produce its own reference interval. Between 1990 and 2008, that IFCC and CLSI published a guidelines that is defining, establishing and verifying reference intervals in the clinical laboratory. Despite the importance of reference interval, most laboratories in developing countries refer to kit inserts, which are based on Western and European populations. It is inappropriate to use reference interval that do not represent the local population. Committee on Reference Interval and Decision Limits of IFCC initiated a worldwide multicenter study on reference values in 2011 to derive country-specific reference interval. This multicenter study was conducted to derive reference interval for Nepalese population. My objective was to derive reference intervals for the following 30 commonly tested biochemical parameters. Methods. This study was conducted according to International Federation for Clinical Chemistry, CRIDL committee and CLSI guidelines. 572 apparently healthy age and sex matched volunteers from 5 major cities of Nepal were enrolled in the study. Blood samples were collected, serum were separated and transported to Kathmandu. And biochemical parameters were measured in Beckman-Coulter AU 480 chemistry analyzer. These are the sites from 5 major cities of Nepal from where blood samples were collected. The source of variation for reference intervals were evaluated by use of multiple regression analysis and nested ANOVA. Reference intervals were derived by parametric method. Latent abnormal values exclusion methods was applied to reduce influence of latent diseases. Reference intervals were standardized based on a value assigned serum panel provided by CRIDL. MRA was performed for each analyte to find potential source of variation. The degree of association of each source of variation was expressed as standard partial regression coefficient. Setting regression coefficient as more than equal to 0.2 as practical importance, age-related change was noted for 6 analytes in males and for 12 analytes in females. Females showed prominent age-related increase, especially for total cholesterol, triglyceride, LDL cholesterol, HDL cholesterol, and decrease for albumin and calcium in case of male. Significant positive correlation with BMI were observed for CRP, C3, glucose, gamma GT in both sexes, while triglyceride, uric acid in males only. A negative correlation with BMI was observed for amylase in females only. No association has been seen in my study with alcohol consumption and smoking level in both sexes. To establish different reference interval with respect to age, sex, and city, 3-level nested ANOVA was applied. Standard deviation ratio was calculated as SDR sex, SDR age, and SDR city. Because SDR city for the analytes were below the threshold, that is 0.3, there was practically no significance between the city differences. SDR sex was computed by 2-level nested ANOVA with age covariate and SDR age by one-way ANOVA separately. Based on SDR gender, more than equal to 0.3 reference interval were partitioned by sex for these parameters. From SDR age, reference intervals partitioned by 45 years were derived for total cholesterol, non-HDL cholesterol, and LDL cholesterol. Nepalese reference intervals were low for urea, cholesterol, ALT, and high for triglyceride and gamma GT when compared with other countries. So These are the final list of reference intervals. List of reference intervals. This side, these are the parameters, and these are the units. Here, the lower limit, and this is the upper limit for these parameters. Similarly, this is also the final list of parameters. The conclusion, the reference interval for major chemistry analytes were derived. The reference intervals can be used for the diagnosis, treatment, monitoring, and prevention of pathological conditions for Nepalese population. Thank you.
Thank you, Assistant Professor Ram Vinod Mathur, for your excellent presentation. Without delaying, I would like to request our next presenter, Ms. Eliza Kesi Bandari. Eliza Kesi Bandari is a registered nurse from Nepal. She graduated from Kathmandu University, and now she is acting as a teaching assistant at St. Luke International University. She is also a health coordinator and is responsible for managing and implementing health promotional activities during the pandemic of COVID-19 among Nepalese immigrants residing in Japan on behalf of NRNA NCC Japan. So I would like to come to you, Ms. Eliza Kesi, for your presentation.
Thank you so much, Indiraji. Ram Vinodji, can you please stop your screen share? Thank you. So namaste, म एलिजा केसी भण्डारी र सरी मैले चाहिँ यो आफ्नो टर्न भन्दा चाहिँ अलिकति छिटो रिक्वेस्ट गरे हैन सो त्यसको लागि सरी So आजको मेरो प्रेजेन्टेसनको टपिक चाहिँ ट्रेन्ड इन सिजेरियन सेक्सन एन्ड इट्स कोरिलेट्स ओभर 2 decades इन नेपाल हो र हाल म चाहिँ डाक्टर अफ पब्लिक हेल्थमा अध्ययनरत छु सेन्ट लुक्स इन्टरनेशनल युनिभर्सिटी जापानमा As you all know, cesarean section is an important indicator of accessibility to emergency obstetric care. An emergency procedure or surgical procedure widely performed to save maternal and fetal lives for preventing complications during labor. But globally, the rate of cesarean section has significantly increased during the last few decades, ranging from 12.4% in 1990 to 18.6% in 2014. Also in 2008, WHO estimated that about 6 million cesarean sections being performed worldwide are medically not necessary. The determinants of rising cesarean trends are multiple and complex, ranging from obesity, advanced maternal age, to different social, cultural, and legal aspects. Hence, the objectives of my study is to examine the trend of cesarean section rate over 2 decades in Nepal from 1996 to 2016, also to examine the correlates of cesarean section delivery based on 5 survey rounds, and finally to examine the changes in these correlates over time. We included all women of reproductive age who had given birth to at least 1 child during the preceding 5 years interval from the year of data collection, and we used the data on most recent mode of delivery. We have utilized national demographic and health survey data collected in Nepal in the year 1996, 2001, 2006, 2011, and 2016, with the permission to use obtained from USAID Demographic and Health Survey Program Department. The NDHS collects data based on nationally representative samples by multi-stage cluster sampling design every 5 years in Nepal, like that of many other developed countries. In this, on pregnancy and childbirth were collected from about 53,000 women aged 15 to 49 years that yielded an average response rate of 98.2% as shown in the table. The main outcome variable cesarean section rate is defined as the number of pregnant women delivering their baby by operative delivery in an institution per 100 live births during the same time period. This is a cross-sectional study design, and we have included the information on maternal sociodemographic, clinical, and institutional factors available in NDHS surveys as our correlates. We performed bivariate analysis conducted using chi-square or FISA-exact test. And in order to examine the correlates of cesarean section in the respective survey rounds, we performed multivariate logistic regression analysis for each of the survey. And in addition, we conducted similar analysis stratified by place of institutional delivery. So this figure depicts the results of our analysis. It shows that the trend in cesarean section in last 2 decades in Nepal has significantly increased, especially for institutional births right here. It has increased by 6% than in year 1996 up to 2016. I have stratified the previous figure here in this one. So you can see like the institutional sectors, public and private sectors. So public sectors are having far more higher cesarean section rates than the public sectors. This table shows the result of our multivariate logistic regression analysis. As you can clearly see from this table that the rate of CS was higher in more advanced regions than the far western developmental region. Also, the rate was much higher in women who with advanced maternal age or those having larger sized baby than their counterparts. Similarly, belonging from the highest wealth quintile and delivering their baby in a private sector had higher risks of getting cesarean section. We also stratified our model by place of delivery, but the correlates were almost similar in both the private and public sectors. So Nepal observed a 6% rise in the institutional-based CS rate in 2016 compared to 1996. This increase might be reflecting the progress in maternal and child healthcare services in Nepal. Compared to 1996 data, Nepal was able to significantly reduce maternal mortality rate related to obstetric complications to meet MDG 2015, 50% MMR reduction using a very concrete national action plan and proper SBA training programs. However, the proportion of CS among wealthiest quintile is almost equal to the national CS rate of some European countries like Italy. Similarly, private organizations might be having way more higher cesarean section rates than public institutions. Since data was based on large nationally representative surveys conducted at 5 time points and therefore widely represents whole country, hence the results are highly generalizable. This study looked at the sociodemographic as well as natal and antenatal factors of women that could affect the CS rate, also reflected on existing disparities in utilization of emergency obstetric care services like cesarean section in Nepal. This study also had some limitations as we did not have data on medical indications of CS, also type of CS, and the previous history of cesarean section, which might have affected our result. To conclude, this study based on 5 waves of population representative data showed that the cesarean section rate had increased substantially during last few decades, which represents a success story of Nepal in meeting MDG goal, as well as UHC agenda of reducing maternal mortality and morbidity by enabling greater access to emergency obstetric care services like cesarean section. This upward trend was fueled by procedures performed at private institutions, where this rate experienced nearly 4-fold increase during 1996 to 2016. On the other hand, an almost unchanged cesarean section rate in the government institutes during this period suggests that there might be a persisting unmet need for cesarean section in the public sectors. However, a regional number of CS being performed in private organizations might be suggesting a commensurate rise in the number of women accessing private sectors because of the incorporation of safe motherhood program and incentive schemes of Nepal government to encourage institutional deliveries in private sectors as well. However, wide disparities exist in CS rate according to wealth index, place of residence, and maternal age. So these are some of the implications of my study. There is still a dearth of studies conducted in Nepal which focused on trend of cesarean section delivery and its correlates. So this study was able to provide a clear picture of the trend in CS delivery in Nepal in the past 2 decades and identified whether this trend is significantly increasing because of various socio-demographic, maternal, institutional, and antenatal factors of women. Considerable disparity in CS rates based on developmental reasons implicates that inadequate number of medical institutions, along with lack of proper maternal and healthcare facilities, are still widely prevalent in some regions. Hence, it is critical time for Nepal government to develop policies which could help balance these prevailing disparities in the utilization of cesarean section procedure so that all Nepalese women can have equal access to maternal and child healthcare services. Finally, shifting the allocation of resources from the region where it might be overutilized to where it is needed should be the focus point at the moment. Thank you for listening. I would appreciate any comments from the floor. Thank you.
Thank you, Elizazi, for your excellent presentation related to the CES delivery trend in past decades in Nepal. Now, without delaying, I would like to request Saraswati Pautalji, who is a master student at Guangzhou Institute of Biomedical and Health Science, China, to come up with her presentations. Elizazi, if we have questions, we will be discussing at the end of the sessions.
Sure.
Okay, Saraswati Pautalji, back to you.
Good morning, everyone. I'm Saraswati Paudal, and my presentation is about prevalence of multi-drug resistance gram-negative bacteria in tissue shell of diseased chicken in Pitwan. The outline of my research include introduction, research question, methodology, result and discussion, conclusion, and at last recommendation. Introduction. Chicken meat and eggs provide high-quality, inexpensive sources of protein, vitamins, and micronutrients. But major disease outbreak in Chitwans are fowl cholera, colibacillus, pasteurellosis, pullurum disease, and salmonellosis. Multi-drug resistance is an antimicrobial resistance to at least one antimicrobial drug in 3 or more antimicrobial categories. Antibiotic resistance is a consequence of overuse and misuse of antibiotics. These are the research questions I'm going to include after my result portion. Why MDR observed highly in gram-negative bacteria, and MDR bacteria are problematic or not? This is the flow chart of my methodology. Samples were taken from diseased chicken and was washed with 70% ethanol to deplete aerosol contamination. Sample was flamed with wet hot blade, and swabs from sample was enriched in peptone water, then incubated at 37 degrees Celsius for 30 minutes. After incubation, 1 ml of contamination of peptone water was further transferred to McConkey agar, nutrient agar, and selenite F growth. Then it is again incubated aerobically at 37 degrees Celsius overnight. Pasteurella, Pseudomonas, and Salmonella samples were cultured in blood agar, XLD, and Muller-Hilton agar, and respectively from nutrient agar, and again incubated at 37 degrees Celsius at 24 hours. Gram staining examination was done, including McConkey agar, for observation of E. coli. Gram-positive bacteria are discarded, whereas for gram-negative bacteria, biochemical tests were performed, such as SIM test, MRBP test, citrate test, urease test, etc. After the identification of bacteria, antibiotic susceptibility test is performed in Muller-Hilton agar. This is an example of AST pattern of Pseudomonas. Result and discussion. Out of total sample, 41% of growth were observed in culture media from figure 1, and in figure 2, boilers were found to be the most infected, followed by boiler parents, baccat, and layers. Distribution in table 1 shows pathogenic bacteria in which E. coli have high prevalence, and the result also indicate about other bacteria such as Klebsiella, Staphylococcus, Campylobacter species, etc., which are discarded from our sample. According to the division of pathogenic bacteria in breed, boiler shows high prevalence of E. coli, and Pasteurella and Pseudomonas are high in boiler parent, and Salmonella in bacad. The representative table shows antibiotic susceptibility pattern of 4 different pathogenic bacteria. E. coli is sensitive to gentamicin and resistance to levofloxacin. Pasteurella species are sensitive to cotrimoxazole and resistance to levofloxacin and amoxicillin. Pseudomonas species are sensitive to gentamicin and sensitive to levofloxacin, and Salmonella species are sensitive to amikacin and resistance to ciprofloxacin. It's shown in the table 4. The frequency of MDR is high in Pasteurella species. Now let me answer the question of my research question that I have included in a second slide. Why MDR observed highly in gram-negative bacteria? It's because gram-negative bacteria has impermeable cell and have property of horizontal gene transfer, that is in between same spaces or different spaces. Usually we call it transformation of DNA. MDR bacteria are problematic or not? Yes, because infection with MDR bacteria are hard to treat since few or even no treatment options remains. When MDR plasmid are transferred to other bacteria, they become resistant to many antibiotics at once. Conclusion. I have already included that high E. coli was observed among all breeds, and E. coli and Pseudomonas bacteria are sensitive to gentamicin and resistant to levofloxacin. Pasteurella is sensitive to cotrimoxazole and resistant to levofloxacin and amoxicillin. Salmonella is sensitive to amikacin and resistant to ciprofloxacin. And different chicken breeds shows high prevalence of multi-drug resistance in gram-negative bacteria. Now let me include the recommendation that veterinarians should prescribe antibiotics after performing antibiotic susceptibility test, and farmers should also be aware on proper use of disinfectant in farm before adding new chickens. Thank you.
Thank you, Ms. Saraswati Paudalji, for your presentations. Since we are a little bit late of our time, I would like to request our next speaker to be very concise in your presentation. And our next presenter is Indra Thapaji, and Indra Thapaji is the 40th student of microbiology at Biratnagar. So, Indraji, can you be with your presentation? Hello, Indraji, are you there? Indra Thapaji, are you there? So I think Indra Thapaji is not in line. So instead we can request Kalpana Yadavji. Are you there? Kalpana Yadavji?
Yes, ma'am.
Yeah, okay, I will request you, Kalpana Yadavji, to go for the next presentations since Indraji is not here in the line. So yeah, Kalpana Yadav is the 4th year bachelor students in microbiology as Birat Multiple College, and we will love to hear from you, Ms. Yadav. Please go with your presentation.
Amen. Are you seeing my slide, ma'am?
Yes, we can see you.
Thank you, ma'am. Good morning, everyone. My name is Kalpana Yadav. Now I am going to give my presentation, and the topic is isolation of Staphylococcus aureus from pod and its antibiogram study. Now, main content is this: my presentation, introduction, objective, background, method, result, conclusion, and last acknowledgement. Now, introduction. Definition of pus. Pus is a typically white, yellow, or yellow-brown form at the site of inflammation during bacterial or fungal infection, which are surrounded by a limiting membrane of the pyogenic membrane. The pus sample was subjected to spread plate culture or nutrient agar media. The pus-forming microorganisms like Enterococci species and Staphylococcus aureus, Pseudomonas aeruginosus, Escherichia coli, Capsula species, and Proteus species. Among these bacteria, I would like to Staphylococcus aureus. Now, background of Staphylococcus aureus. Staphylococcus aureus is a gram-positive, round-shaped bacteria frequently found in the upper respiratory tract and on the skin. Infection is a major bacterial human pathogen that causes a wide variety of clinical manifestations. Infections are common in both community acquired as well as hospital acquired settings, and treatment remains challenging to manage due to the emergency of multi-drug resistant strains such as MRSA. MRSA means methicillin resistant Staphylococcus aureus. The multi-drug resistant Staphylococcus aureus play a key role in the epidemic of this infection. Now, main objective of my presentation are isolation of Staphylococci from pus sample, isolation of Staphylococcus aureus, identification of Staphylococcus aureus, antimicrobial susceptibility pattern of Staphylococcus aureus. Now method. This study was conducted during December 2019 to February 2020 in microbiology laboratory at multiple college. Altogether 50% sample were collected and processed for culture and subculture in MSA and NA media. MSA means mannitol salt agar and NA means nutrient agar media. After 24 hours of inoculation, golden, yellow and white colony were subjected for biochemical test and antibiotic susceptibility test. Antibiotic susceptibility test was carried out by Muller-Hilton agar media by this diffusion method followed by Haber-Brewer technique. Biochemical tests that were used for isolated colony were oxidase test, catalase test, coagulase test, urease test. In oxidase test, result was negative. In catalase test, result was positive. In coagulase test, result was positive. And also in urease test, result was positive because of presence of ammonia. Now sulfur test, indole test, mortality test. In sulfur test, result negative. Indole test, result negative. Mortality not mortal because of no cloudiness was seen. Now TSI, slant was red, board yellow, carbon dioxide absent, H2S absent. In table 4, indole test, initial and final, there is both yellow color. In methyl red test, initial both yellow, so negative, result was negative. In bogus Proska test, initial yellow, final red, so result positive. In cited utilization, initial green, blue, final blue, so result positive. Here now result, out of 50% sample, the significant growth were seen only in 7, that is 14% sample. The obtained isolated were subjected to different commonly used antibiotics to understand the sensitivity, intermediate, and resistant. Among 7 isolated, all the 7 unsampled were resistant to penicillin and 42.86%, 57.14%, 85 and 70% were sensitive to cotramazole, gentamicin, and penicillin respectively. Now here table antimicrobial. There are altogether 6 drugs, that is ampicillin, no sensitive, intermediate, and resistant vaccine, anthromycin. Sensitive 14 to 28%, 14 to 28% intermediate, and here and cotrazmozole 57.14%, 42.86%, and here in penicillin sensitive was not seen, and in vancomycin resistant was not seen. Here now conclusion, vancomycin and gentamicin should be prepared for Staphylococcus aureus. Last acknowledgement. Thanks to Manish Dal, sir, Upendra Kumar Chaudhary sir, and Miss Sweta Kumar sir, all the faculty member of microbiology and my friends. Thank you for giving me this opportunity.
Thank you, Ms. Kalpana Yadav, for your presentation. Now I would like to request Dr. Subhash Chandra Chaudhary for his next presentations. And Dr. Chaudhary, please be precise as we have very short time left. And Dr. Subhash Chaudhary is a postdoctoral research fellow in Chennai National University Hospital Cancer Medical Center. So I will just like to request him to be very short and precise in your presentation. Back to you, Dr. Chaudhary.
Okay. Have you seen?
No, I cannot see you. I can just see your screen, computer screen, not the PPT.
Come?
Yes, we can see you.
Okay.
Can you share the full screen?
You can do slideshow. Slideshow.
Slideshow.
Yeah.
Slideshow.
Yeah, from there. Slideshow.
Mati, at the top you can see the slide.
Okay, yes.
Yeah, 5 minutes. Like.
Wait. Why? किन के भएको
तपाईको त्यहाँ केही बटन थिचिरहेछ कि किबोर्डमा
होइन त
ओके 1 मा क्लिक गरेर F5 थिच्नुस् त फुल स्क्रिन हुन्छ
F5
अनि
यो चाहिँ लास्ट
ओके होम बटन थिच्नुस् न we have very few minutes left है अब फेरि 2-3 minutes भनेको छ मैले आईटी टिमलाई एक्सटेन्सनको लागि रिक्वेस्ट गरिरहेछु
के भएर हो
के भयो विलेना माथि
I think we should go to another speaker if possible.
Meanwhile, Dr. Chaudhary is preparing for his presentation. I will request Indra Thapaji, is your screen sharing working? Or Indra Thapaji?
Yes, ma'am, I am here. I would like to.
Yeah.
Yes, ma'am. Morning, everyone. I would like to share my screen instead of file. It is not working.
हाम्रो टाइम प्रब्लम छ हैन तपाईले शॉर्टली गर्नु पर्छ भनेर भन्नु भयो
we can see okay go ahead
Indraji, we can see your PPT, you can go.
My topic is ubiquity of extended spectrum beta lactamase producing gram-negative uropathogens in Viratnagar, Nepal. And first of all, I would like to give some information about Enterobacteriaceae and Pseudomonas. Enterobacteriaceae is a large family of gram-negative bacteria, facultative anaerobes, non-sporoformers, mainly found inside the gastrointestinal tract. And it was first proposed by them in 1936 and now includes over 30 genera and more than 100 species. These organisms have simple nutritional requirement, and McConkie is used to isolate and differentiate organism of Enterobacteriaceae family. Usually, these bacteria forms, gram-negative bacteria forms pink color on the McConkie agar. And non-lactose fermenter are generally colorless or pale in color. Gram-negative Enterobacteriaceae are catalase positive and oxidase negative, being different Pseudomonas from catalase positive, oxidase positive, MRBP both negative. It is slightly different from the Enterobacteriaceae. Some members of Enterobacteriaceae are a part of the normal flora and do not causes disease in normal condition, but can causes disease in immunocompromised patient, as a person having the low immunity. And these are the some examples of the Enterobacteriaceae like Citrobacter, Coronobacter, Enterobacter, Escherichia coli, Herpes, Klebsiella, Pentuea. These are the some examples of the member of the Enterobacteriaceae. And I would like to tell some about urinary tract infection. A urinary tract infection is an infection in any part of the urinary system. It can affect gram-negative bacteria can affect your kidneys, ureter, bladders, etc. Most of the infection involve the lower urinary tract, the bladder, and the urethra. Women are at greater risk of developing UTI than are men. That may be due to the shorter urethral anal and vaginal proximity. Based on the location, UTI are of three types: pyelonephritis, infection of the kidneys; similarly, cystitis, infection of the bladder; and urethritis, infection of the urethra. And again, extended spectrum beta lactamase. Extended spectrum beta lactamase are plasmid coded enzymes that are confer resistance to most of the beta lactam antibiotics. Those antibiotics having the beta lactam in their ring, including penicillin, cephalosporin, generally first, second, and third generation of cephalosporin, and monobactam and azithromycin. beta-lactamase provides antibiotic resistance by breaking the antibiotics structure, especially beta ring like break गर्छ यसले. These antibiotics all have a common element in their molecular structure, a 4-atom ring as a beta-lactam. Through hydrolysis, the enzyme lactamase break the beta-lactam ring and open, deactivating the molecules antibacterial properties. And this is the structure of the beta-lactam antibiotics. Beta-lactam, and this site is the beta. This site is the site for the beta-lactamase attack, and these are alkyl group is different for different antibiotics. This is same. And clavonic acid. Clavonic acid is a beta-lactam drug that functions as a mechanism-based beta-lactamase inhibitor. It is the beta-lactamase enzyme inhibitor, while not effective by itself an antibiotic. This is not an antibiotic. When combined with the penicillin group antibiotics and cephalosporin group of antibiotics, it work as the effective antibiotics. Effective antibiotics. Some example, ceftriaxone is the antibiotic which is generally hydrolyzed by the ESBL producer bacteria, and if it combines with the clavonate, it becomes the choice of the drug for the ESBL producer bacteria. Similarly, ceftazidime clavonate, amoxicillin clavonate, etc. are the examples of the and my result is here. Total samples analyzed were 50 significant bacterial group, 33 E. coli. Among 33 isolates, 21 were E. coli, 6 were Klebsiella pneumoniae, Pseudomonas 3, Proteus species 2, Citrobacter species 1, MDR isolates. Yes. MDR isolates, E. coli 16, Klebsiella species 3, the total ESBL producer by PCDDT phenotypic combination double dix test बाट E. coli, total E. coli, ESBL producer E. coli were 8, Klebsiella 1, making a total of 9. Thank you, everyone.
हामीसँग टाइम छैन इन्दिराजी?
सुभाषजीको छिटो गर्न सकिन्छ? सुभाषजी तपाईको शेयर के गर्न सकिरहेछ? डाक्टर सुभाष,
सबै स्पिकर्सलाई थ्यांक यू फ्रम हाम्रो साइडबाट है। अब सुभाषजीले सायद आउनुहुँदैन होला।
सुभाषजी तपाईको छिटो झ्याउन सकिन्छ भने एन्ड गरौँ न। तपाईको प्रब्लम भयो भने म शेयर स्लाइड गरिदिन्छु। Subhashji, I think we lost Subhashji, so maybe we can conclude here.
So we would like to thank everyone. अब हामीसँग टाइम पनि छैन। सबैजनालाई thank you very much, invited speakers and general presenters. It was a good time, but because of the short time duration, we couldn't include Dr. Subhash. We are very, very extremely sorry for that. Right? From now, I would like to conclude this session. Thank you very much.